Hi everybody, it's Dr. Jason Frank speaking from the Royal College of Physicians and Surgeons. We're just about to begin our latest Competence by Design CanMeds 2015 webinar. Thank you so much for joining us. There's more than 100 people signed up for today, and we're still gathering people from across the country and around the world. A couple of things to remind you about in this webinar series: that your lines are muted, so don't worry that we're listening in on anything you say, or I want you to be aware that if you want to ask a question, it's not through audio. It'll be by getting you to type in the question box in the bottom right-hand side of your screen. There's a little panel that comes with this software, and you can type in there, and our team is standing by to collate all the questions, and I'll be pausing at regular intervals to answer your questions. If you have technical problems, you can email us at CanMeds, and we'll try and help you from our end, but it might be your local IT department needs to help you to enable things. And this whole recording and slide deck will be put on the web. So I understand that our webinar series has been very popular, and it's been downloaded many times every time we release a new episode. Today's is, I think, the 5th of this Competence by Design CanMeds webinar series, and that'll be posted shortly. We'll also send you a quick survey after the webinar to give you an opportunity to give us some feedback. Tell us any questions that you thought of after we were all wrapped up. So let's get started, shall we? So this is the update on the Competence by Design project. And this is the biggest project that the Royal College has ever been involved in, a truly transformative proposal to modify Canadian medical education. It's being watched not only by all of you, but by educators from around the world. People are watching what Canada is doing to reform medical education. And once again, my name is Jason Frank. I'm the Director of Specialty Education here at the College in the Office of Specialty Education. I contribute as part of a team of people here, a large team that is moving to implement the Competence by Design proposal. So here's what we're going to cover. Our agenda today is to once again remind you about the rationale of Competence by Design and what it is that's really different. So the major emphasis on this webinar is to tell you about the contrast between our current system and the proposed system that we're looking to roll out. And in particular, I'll spend a bit of time on CanMeds 2015, on the e-portfolio that's about to be launched, and how we'll implement this in a phased way with each of our disciplines. And we'll finish with a couple of thoughts about why it's so important to get this done. If at any point you have any questions, feel free to type into that box on the right-hand side that we talked about, and we'll collate those. I'll stop at regular intervals and gladly try and answer your questions if I can. And if there's something I need to go and look up, the team and I will get back to you. And we really are looking forward to your comments. So let's dive in. Let's talk about the journey of a resident in the current model versus the proposed model. We've found in our discussions and presentations over the last few months that this really helps to illustrate what's being proposed. So meet Andrea. She is a resident in a Canadian contemporary education system. She's in a program in one of our universities. And by the way, our residency education training system here in Canada is considered among the best in the world. Those of us who travel in medical education to other countries, you know that our system is highly sought after. It's recognized as being one of the best. And there are a number of features that we want to preserve. So all the changes that we're about to discuss are related to improving the system, keeping the best of what we're already doing, and adding some 21st century educational technology to it. So truly what we're presenting is a hybrid. So let's go back to Andrea and her contemporary program. It looks something like this. Andrea matches out of a Canadian medical school through CARMS, or from an international school, again, usually through CARMS. And she goes into something like a basic clinical training year, which has a broad number of rotations. She spends time on various wards, and she acquires some competencies. She then becomes a junior resident in her core program. Progresses through various in-training evaluation assessments, IDERs that are filled out at the end of blocks. The block can be a month, 2 months, 6 months, depending on the discipline. And then she becomes a senior resident, has more responsibility, starts to prepare for her exams, and again has in-training assessment, often end of rotation, but sometimes a variety of other assessment methods are used in Canada. You'll see multi-source feedback, you'll see the occasional OSCE. Most specialty programs would be using oral exams at some point, and decisions are made about allowing Andrea to progress as she's acquiring greater and greater ability. At some point, Andrea realizes that their certification exam from the Royal College is upcoming, so she really starts to focus her life on preparing for that exam. And one of the complaints of both residents and faculty is that trainees really have to dedicate their lives, it seems, to preparing for the Royal College exam, given that it's such high stakes. And once Andrea successfully completes that exam late in her residency, if she's in a primary specialty, she will be certified by the Royal College, and she'll either move on to a subspecialty or move on to practice. So that's our current model. So what are some of the challenges with that current model? Because remember, we have evidence that says that Canadian training is considered excellent around the world, and we want to preserve the best of it. However, there are some challenges that we have been tracking for some time and are concerned that need to be addressed. So here's a bit of a rundown. We get feedback from program directors and other teachers that residents can be disempowered in our current system. If you think about it, when Andrea arrives on her first day of residency, she can almost map out the next number of years in training. In fact, she can almost map out where she's going to be, when she's going to be doing what rotation over the next few years, because we have a system that's very much based on time. It's based on how many numbers of weeks you spend in what ward, and we hope that while you're there, you'll be acquiring all of the competencies that are written out in our national training objectives. Unfortunately, that can mean a trainee can be a bit passive. They can move from rotation to rotation without thinking of their own progress towards becoming the best expert in a discipline that they can be. And so there's a bit of a disconnect there. There's great burden placed on faculty. So faculty have a lot to do in terms of supervision, keeping trainees and patients safe. We ask them to complete a lot of assessment forms, and there's a lot of teaching that's done, usually in an academic half-day format at every program in Canada, where each program actually reinvents that wheel for their local site. We have more than 800 programs in Canada, plus many, many more teaching sites. There's some concern about the teacher-learner exchange, and so the term used here is the corruption of the teacher-learner exchange. I'm going to define that educational jargon for you. The concept is that instead of orienting our teachers and our trainees towards really useful feedback that spurs the learner on to the next stage of development, instead we have people who take their pen and go down the page on filling out the forms in a way that isn't really useful for learning. And learners often complain in all of the studies that have been done in the Western world that they don't get really useful assessment for learning. So meaning their feedback's not really helping them become the best doctor they can be. Failure to fail is something else that's been documented in our system. It speaks to the idea that in our system it's either very difficult for supervisors to give hard-hitting feedback when someone is not at standards, or that we have systems that are built that are not optimal to help somebody remediate. So all of us probably have colleagues that we've talked to, or you've experienced scenarios in which our colleague tells us verbally that somebody's not doing so well, that they're concerned about some behavior that they saw in terms of the work of a trainee. And then when that colleague is asked, did you document this, did you put it on an assessment, will you put it in writing, they may be reluctant to do so. And there's a number of reasons for that. We need to build a system where that's both useful and easy. Dichotomous judgments. You're either competent or not, or even worse, you're good enough or not in terms of addressing trainees' progress through our system. And we want to make assessment a little bit more sophisticated and oriented towards helping people become more expert. Our system is such that we have little opportunity for direct observation, and even when trainees are observed doing something, we have systems that don't really capture that data. So an example is a trainee might be in the operating room with a master surgeon for 8 hours in a row, but they both leave that room and scrub out and move on to new tasks without actually taking advantage of that precious time together. And finally, as I alluded to in the Andrea scenario, we have high-stakes national exams. In fact, our system depends upon this third-party biopsy of somebody's abilities to make really important decisions about their future ability to practice. So is it any wonder that trainees are, quote, lost to follow-up as they immerse themselves in preparing for such a big point-in-time assessment? So that's a bit of a snapshot about some of the challenges that have been brought to the Royal College's attention. A little bit more about those system challenges. Learning is still judged by time spent, not ability achieved. There is some evidence that trainees are unprepared at stages. And so thinking about the transition from an undergraduate to a postgraduate, from a resident on into practice, we have good evidence that says that people often feel that they're unprepared for each change in their career. Another example is the movement from junior trainee to senior trainee. We've already talked about workplace-based assessment challenges and failure to fail. We have a culture that says that we need to be far more attentive to keeping patients safe in our contemporary system. And that's because we're much more aware in the 21st century about the potential for patient harm. So this is now thrown into the mix where we're trying to optimize resident training. There are some programs that have, quote, missing content, and that refers to the idea that not all the CanMed's roles are taught and assessed in every program the way that the specialty training committee wants them done. We have faculty that we're trying to ensure that their precious time is allocated to the training programs efficiently. There is very little new money to inject into any system. We also want to enable a system that has true lifelong learning. We have data in the literature and reported to the college that says that people, when they exit into practice, still feel unprepared for a career of keeping up with the changes in their discipline, and also for the changes in their scope of practice as it evolves over time. So how can we prepare people for that better? I myself, my colleagues, I have conversations about how you keep up with all that mountain of literature. And there's some skills that I've acquired over time, but they weren't skills that I learned in residency. There are things that I either learned from really smart people or I learned from trial and error. We want to make that easier. And another theme that I've alluded to already, we need to reorient assessment so that it's for learning, not of learning. So we want to move away from this dichotomous, are they good enough, are they keeping up enough, to where are they at and how can we help them fill their gaps. So again, this is some overview of the challenges we see in the system, and it's actually part of the rationale for making the changes. Okay, so change is underway. It's actually competency-based approaches are underway around the world, and our version here in Canada is called Competence by Design for Royal College specialty programs. So this idea of using competencies and defining the steps along the way can actually be made graphically like this. So you'll see across the top this idea of using sort of a Dreyfus model, it's called, where someone moves from novice to master clinician. And this applies to just how the human brain works, whether it's in music or sports or any other endeavor. It seems as though the human brain, as it acquires expertise, can actually behave in a way that looks like these patterns. You can actually pick out somebody in a short video what level of skill they have in a domain. I'm going to introduce to you in a second or remind you of this concept of milestones, which are statements of a physician's ability expected at a stage of development. We can actually write statements that say, this is what we'd expect a beginner to do, this is what we'd expect somebody who's at a certain level to do. And if you can conduct assessment to see where somebody's at, you can actually graph their progress. And that's what this figure here is supposed to remind us about. So ultimately, this is an approach which is about ensuring that individuals in our medical education system display the abilities that are needed for the context they're working in at the time. This is a staged approach to medical education. Okay, so let's define competence by design. So competence by design, as we've said a number of times, is this flagship project of the Royal College in Canada. It promises to be transformational, but I want to remind you it's a hybrid. We're trying to preserve the best of our system while incorporating the best of competency-based approaches. And fundamentally, it's a move away from time-based training, where judgment is made on your ability based on how long you spent on a ward with a pulse. Instead, we wanted to move towards evidence of achievement. So many of the things we're already doing just need to be reoriented to that culture and that view. This is a commitment to the continuum medical education. We want to make the transitions smoother and more logical. So out of undergraduate into residency, out of residency into practice, and for lifelong learning. And as we said, this is a competency-based approach, and ultimately what we're doing this for is for our patients. We want to prepare doctors for the 21st century. The next slide is our diagram of how we're thinking about the stages of training. So right now, if you think of residency and on into practice, most of us would think of years. And residency would be postgraduate year or PGY. And undergraduate would be what year, whether you're in clerkship as a junior clerk, a senior clerk, or a variety of hybrid models. And then with respect to lifelong learning, it's about your years in practice. The Competence by Design project actually gives a bit of a schema in terms of these changes. So on the left-hand side, you see some traditional stages that we all have used over the years. But in the middle, we give you this new language. So coming out of the MD programs, the first stage that we're going to ask disciplines to use is called transition to discipline. The next is foundations, followed by core, and finally transition to practice. And then on to lifelong learning, continuing professional development. I'll come back to the last stage in a moment. So let's define these a little bit. Transition to discipline is a brief period in which a trainee or a group of trainees can be oriented to this discipline, how learning will occur in this discipline using the new Competence by Design approach, and also some initial assessment to see where people are at with respect to the milestones of that discipline. That allows a tailored training program to be made. Each of these stages will be constructed by each of the disciplines. We'll give a framework for all of the disciplines, but specialties and subspecialties will then decide on how much time, rotation space, what milestones will be allocated to each of these. Foundations of a discipline will be the next stage, and that stage deals with some broad-based fundamentals that prepare that trainee to move on to the core of the discipline, to have greater responsibility. A big change in this new system is the intent to move the Royal College examination back from the last act of residency to the end of core of discipline. And this is a third-party check, independent body's check on the trainees' core abilities that they've acquired so far. But that is not the point where the Royal College will declare them able to practice independently. Instead, we've added this new stage called transition to practice. And this is at the request of trainees and educators from across our system. And transition to practice is akin to what is already happening on the ground in terms of junior attending rotations or chief surgical resident. And the idea is that person has considerable amount of autonomy. They make decisions about patients still under supervision, but the supervision is a little bit more distant. It allows more room for that person to behave like they will in practice. And the goal is to ensure that that person is truly practice ready and that on their first day of independent practice outside of their residency, it's another day at work. Trying to make those transitions between phases of someone's career a little bit smoother. Certification will occur in the new system when the residency program committee signs off that trainee as being ready for independent practice. That can only occur after a period in transition to practice. With respect to continuing professional development, we consider this both maintenance of competence and enhanced expertise. And by that we mean ongoing improvements in an established scope of practice, and as well there are some learnings around when a physician changes their scope of practice. So continuing professional development is actually the biggest stage in the Competence by Design continuum. The final stage we've added recently, and so it's still in development, but at the request of our colleagues who work in CPD and at the request of our colleagues who work at medical regulatory authorities, they've asked us to add the stage called transition out of professional practice. And the idea is that there are a number of competencies that are actually needed for this unique period of someone's career, and we're going to write milestones for this period as well to give people guidance. An example for this stage might be what a physician needs to be able to do to ensure they meet their medical legal obligations, obligations to their patients in terms of their medical records, and making sure that there's care accessible for them, ensuring that someone has insight into procedures they should stop doing for a variety of reasons. Those kinds of issues will all be part of transition out of professional practice. I'm going to pause in a few minutes to take your questions, but let me just cycle back to Andrea's journey under the new Competence by Design residency model. So we're going to move away from those junior rotations, senior rotations, time spent on wards, and now we're going to use those new stages. So orientation and assessment, where Andrea will meet her new e-portfolio provided by the Royal College. In that e-portfolio, unique to Andrea, will be an interface that says, welcome Andrea, see that you're a resident in this discipline. Here are your milestones laid out for you that you need to upload evidence of achievement and get signed off over the course of your career. There'll be an area in that e-portfolio that gives room for Andrea to type in some self-reflections or self-assessments that will only be visible to her. There'll be parts of her e-portfolio that are visible to her program director, and then again parts that are be uploaded to the Royal College for credentialing. Andrea will progress through the stages as laid out here, but as she progresses, she'll be going through a number of assessments that are defined nationally by her specialty committee. So no longer will each of our 800 and some program directors have to reinvent the wheel, invent new assessment tools, and deploy them on the ground that are unique to each site. Each specialty committee will produce a number of assessments that will be deployed nationally and adapted locally to the program's current reality. And finally, as Andrea completes the core of her program, she'll then have access to the Royal College exam. When she practices that, she'll be eligible for transition to practice, and when her program signs off, she'll be certified by the Royal College. An important note about this new system, it's truly a hybrid, so there will be ward-based rotations just as there are now, but time will become a resource, not the organizing framework. If Andrea is progressing rapidly through her program and achieving milestones faster than the average trainee would do, she can meet with her program director to plan her next year's rotations so that she can actually exit a little bit earlier. If a trainee needs a bit more time, or perhaps a remedial rotation or additional time during her planned rotations to catch up on some milestones that would be expected at that stage, then the program director and that trainee can then again revisit what the plan is in terms of where she'll be allocated and what ward she'll be working on. Okay, so that's Andrea's journey. I think we have a number of questions coming in. I'll stop here and see if I can address a couple of them. Okay, the next one. If a resident is unsuccessful at the examination, do they return to core of the discipline, or do they move to transition to practice and resit the exam following that phase? That's an excellent question, and so it speaks to what do we do with trainees that aren't quite on the track that we thought they would be. What I anticipate is it's more the latter, that someone will move on to the next stage but have opportunities to catch up the things that they're missing. However, it's a bit more nuanced than that, in that each discipline will set some rules with respect to how many times someone can attempt certain stages, such as going through the exam. The discipline will also set which milestones are absolutely essential, meaning you can't progress on if that milestone hasn't been achieved, versus some milestones that may be a bit more elective, and you can come around to them again using your next stage of training. So there will be some nuances in this, and you'll look for some more details that will be released from the college next year. The next question I have is, for the transition to practice and foundations of discipline, many disciplines will have overlap of competencies. Will there be a collaborative project to develop these competencies rather than each discipline reinventing the wheel for common competencies? The honest answer is we're not sure to what extent competencies will be, quote, common. I know that there's a move in the U.S. to have some of the more generalist disciplines share some EPAs and milestones there. Here in Canada, we're going to ask every specialty to take the higher order CanMed's competencies and adapt them. And we won't know how many of those will be significantly adapted until we get the first few cohorts going through. More about that later. I'm going to look at the next question. Will the opportunity to sit exams increase in frequency given that the residents may be progressing at their own individual pace? That's an excellent question. I don't, again, have an answer for you about that today. We will be having, hopefully, an upcoming webinar with Farhan Banji, who's the current Associate Director of Assessment, and I'll bring that question for him to that webinar so that he can answer that for you. The next one is a competency-based approach moves away from time-limited residencies. The current structure, including funding and regulations, are very rigid with respect. Could you comment on this? Absolutely. So remember I said that this is a proposed hybrid system. The idea is to use the best of competency-based medical education, but try and implement it in the context of our current time-based system. So as I said, trainees will still have obligations on to awards to provide service. That's what resident contracts are based on. However, what they're assessed on as they go through each of these wards and spend time will change, and that's our focus on these milestones and evidence of achievement. With respect to remedial for the trainees that need additional time, we already have a system in Canada that allows that to happen. So faculties of medicine have ways of allocating additional time and occasionally additional resources, and they have rules of the game that allow for remedial to be conducted and judged as to whether or not it's completed or not. So those kinds of things will always occur. I do not anticipate a world where there'll be chaos, that trainees will be moving at different rates and therefore some wards will be uncovered. In the new hybrid proposal, we don't want that to happen. Instead, a year's worth of rotations will be planned just as they are now, but there'll be a dialogue between a program director and an individual trainee as to what rotations they'll use to achieve the remaining milestones that they have before them. I'm going to move on with a few more slides and I'll come back to your questions in the next section. Those are great questions, by the way. Okay, how do we get to this new world? Let me tell you just a little bit more about some of the components of competence by design. If you've attended previous webinars, you've heard about this already. I'll give you some updates. So the next slide is a bit of an at a glance. It's a busy slide, but it's to impress upon you how much work is being done to prepare for this new system. So you've heard me allude to an e-portfolio that will follow a trainee in the new system from their first day of residency to the last day of practice. It will grow and change with them as they change. For residents, it'll help them upload evidence of their milestones. It'll signal when that they're have completed all the milestones in a certain stage and they can move on to another stage. It will flag for the college when they're eligible for the college exam. And the e-portfolio will be the document that program directors will digitally sign off on to allow a trainee to become certified in the discipline. For fellows like myself and many people on this webinar, this new version of our e-portfolio will be quite different than the current main port. And it'll be tailored to our own specialty or subspecialty or other discipline. And it will allow us to also tailor it to our unique scope of practice. So for myself, I'm an emergency physician. I'll be able to log into my future e-portfolio and it'll say, welcome Jason Frank, I see you're an emergency physician. Here are the milestones of emergency medicine you can use for your own CPD. Similarly, it'll grow and change with me as I add new scopes of practice or change my practice. Our assessment system in Competence by Design is changing significantly. So we're moving away from a system which has heavy emphasis on a high-stakes exam and low emphasis on workplace-based assessment. We want to move that pendulum a little bit closer to the middle. We want much more workplace-based direct observation that's recorded and uploaded to an e-portfolio and a little bit less on this third-party biopsy. Our accreditation system is going to change to be more oriented towards program outcomes and less oriented to program process. So while we'll expect every program to have its own system in terms of which rotations they allocate where and so on, we'll have a greater emphasis on how are your trainees displaying their milestone achievement curves. And we'll be able to compare that to peer programs and have a discussion with the program director about what's working and what's not. Credentialing will move away from counting how many months somebody spent in various rotations and move towards the e-portfolio being emphasized as emphasis on what milestones have been achieved that match the profile of a certain discipline. CANMEDS 2015 is the foundational building block of all of this, and it's nearing its completion as we speak. That project's been underway for about 3 years. I'm going to tell you more about it in a moment. So this is Competence by Design at a glance. So let's talk a little bit about CAMEDS 2015 and the ePortfolio. So as you know, the Royal College has been using this framework of 7 domains of physician competencies since 1995. And it's actually been adopted in 30 jurisdictions now around the world. And we've updated it. So it was original framework was live in 1996. We updated it again in 2005. And now we're about to release CAMEDS 2015, 10 years later. So we want to keep the framework fresh, up-to-date, contemporary, but we don't want to change it too often so it becomes a bit of a bureaucratic challenge for everybody who's trying to run a residency program and other education programs. So this is a draft CAMEDS figure, and it's moving away from a bit of a flower motif to towards more of a compass of competence. And we'll be talking a lot more about that when CAMEDS 2015 is officially launched, which is at the International Conference on Residential Education 2015. That'll occur in Vancouver. CAMEDS 2015 will be rolled out there in its final form, and as well it'll be accompanied by a number of faculty development initiatives and publications that will go with it. So we hope that all of you who are on this webinar will attend in Vancouver. We'd love to have you. So CAMEDS is different not only because we're updating the competency framework to include some of the latest thinking in each of the domains of CAMEDS, but we're also adding the system of milestones. So you see on your screen on this slide a bit of a snapshot from the publication we're about to release in just a short number of weeks. In September, we'll release the 3rd draft of CAMEDS 2015. In February, we released our first version of the new framework. In the spring, we released the next version of the framework as well as the first draft of milestones that extended from undergraduate all the way up to the end of practice. And these are statements that are by stage. So what ability would you expect a trainee at that stage of their career to display? So this is how the table will look. It'll be more extensive. Obviously, it'll cover all of CAMEDS when we publish. But Series 3 will list the key competency. You'll see that up above going across. Here it's number 1, contribute to the improvement of healthcare delivery. Then the enabling competencies are rows that you see underneath. So an enabling competency enables those, prepares someone to be able to do the key competency in our way of thinking. And then across from left to right are a series of statements that are the stepping stones. So if you assessed an individual using these competency milestones from CAMEDS, you should be able to have a snapshot of what they're able to do at this point for each of the CAMEDS domains. And we are providing this as a resource for all of the specialties and the Royal College and others around the world. So Series 3 version of CAMEDS is about to be released, and you'll have a series of these tables within it that'll give you the next draft language that deals with these stepping points. So the manager domain in CAMEDS 2005 is being proposed to change to leader in the next version, and that's to emphasize leadership. And you can see here a couple of examples. For example, the enabling competency, analyzed adverse events and near misses to enhance systems of care. This speaks to patient safety competencies. And you can see that our expert working group have written statements that speak to, as you enter the discipline in the new system, they expect you to be able to say, describe elements of the healthcare system that facilitate or protect against adverse events or near misses. And then moving from left to right, the individual should be able to display increasingly more sophisticated abilities in that domain as they move towards independent practice. So stand by for the release of that official document in the next few days. So a little bit more about milestones before we move on to ePortfolio. So milestones, you've heard me say, are statements that speak to the expectation of a physician's ability at a stage of training. And you can see how milestones can be used for curriculum, so they can be allocated at each of the competence by design stages. And they can be used for assessment. It allows us to take a measure of where someone's at in terms of their progress towards independent practice. So they're very powerful statements, and they're being used around the world. It's a very avant-garde approach to medical education. I want to emphasize an important point that comes as a result of the feedback from previous webinars. There are a couple hundred milestones for residency alone, and that's because our expert working groups have very, very carefully and dutifully written statements at each stage along the way. And I want you to know that we're not asking every discipline to use each and every one of those statements. Instead, we think of it as kind of a palette or menu that is available for each discipline to then select from and say, we're going to use that milestone there and this milestone here to actually assemble the criteria for progression in their own discipline. So that's an important point to share with all of you. So what does Andrea get out of this new system? She gets a different assessment system, perhaps more frequent, but definitely much more meaningful. So no more feedback with a pen going straight down the page saying thanks for helping out on the ward. Instead, it's going to be, Andrea, we observed you doing this milestone. You displayed this level, and that's fantastic because it exceeds our expectations at the stage. On this other milestone, we want you to get to a higher level, so we need to work on that during the rest of your time with us. That really changes the dialogue between supervisor and learner. We hope that this helps learners to own their own training. If they can see their own pathway to mastery of their discipline, we think that's going to help change the culture and change the dialogue where trainees are much more proactive about the things that they want to acquire in each rotation and getting observations done while they're doing their work. We think this also lends transparency to the whole system. Teachers, learners, program directors, regulators, everybody involved has these statements available to them as each specialty publishes their milestones. And so we all know the progression of competence for each discipline. We think that ultimately trainees will be better prepared to serve patients and better prepared for independent practice. We also think that this whole system allows for a greater flexibility for the few individuals that might need a little bit more time on a few milestones, or perhaps can move a little bit quicker because they've done well and managed to acquire some milestones a little bit quicker. Okay, a little bit about the e-portfolio and something we call e-diploma. If you've been on our webinars before, you've seen this slide. We're investing heavily in developing the next generation e-portfolio to support all of this evidence of achievement. The first version, our pilot project, was called e-Diploma, and we used it for the Royal College's diploma programs, or the areas of focused competence. So if you're in transfusion medicine, you can complete your program in a time-free way. So you upload these milestones as you're working in within the transfusion medicine curriculum. A supervisor signs off, and the graphical interface tells you how far along you are in terms of your degree of achievement. And when you've completed all of the milestones in your e-diploma, you can submit them to the college to become certified as a diplomate. This is the beginnings of the technology and the interface that we're going to use for the e-portfolio that will roll out for all of us who are in the Royal College system, residents and fellows in practice. Quick snapshot of all of the features of the e-portfolio, and I've been alluding to them as we've been discussing along the way. So not only does the e-portfolio allow you to upload evidence of milestones, it also allows you to select supervisors from a drop-down list and get them to sign off on them. There'll be a section of the new e-portfolio that'll be completely private to the individual fellow or trainee. There are parts that they can share with others, like program directors, or to make reports that they can export, perhaps to a medical regulatory authority or to a department chair for hospital reappointment. There's an opportunity to see what your colleagues are doing and collaborate on certain aspects of a discipline. So the new e-portfolio we're pretty excited about, and it's underway. Okay, so how are we going to roll this out? Just to finish this section, and then I'll do some more of your questions. The plan developed by my colleague Jolanta Karpinski and her team, including Jennifer Stewart, is to roll out in a series of cohorts this new system. So the Royal College won't be flipping a switch so that the entire medical education system changes overnight, but instead we've actually stratified all of our existing disciplines, invited them to put forward their desired time to change, and there's a variety of opinions. So we have some disciplines that are ready to change yesterday. They're so excited about this possibility that they've already perhaps written their own draft milestones. they're ready to go and their community is ready to go. So our first two Competence by Design adopters, our pioneers, are medical oncology and otolaryngology. And we've really enjoyed working with them so far. In fact, medical oncology's senior educator team are going to be here at the Royal College for 3 days next week, where they'll be making their Milestones suite. Otolaryngology will follow a few weeks after that. And the first cohorts of these two disciplines to be using the entire new Competence by Design system will start on July 1st, 2016. We're prepared to work with the next cohort of the approximately 7 new disciplines starting in 2015, and those will be announced shortly. I think the emails are actually going out today. And after that, we'll do 10 to 15 per year under this current proposed system, where we'll work with a number of disciplines, get them to take their current standards of training and adapt them with this new stage-based, milestones enhanced approach. So as we said, the first cohort is medical oncology and otolaryngology, and about 7 disciplines next year, and then 10 to 15 each year after that until we're done. Maybe I'll just pause here and take some more questions. If the team could please put up that slide with the questions. Okay, the first question is a recurring theme. It's about scheduling. So scheduling can become difficult with different amounts of time spent in each rotation for each trainee. How will this be addressed? And I'll just pause there. The person has a couple other questions. I want to emphasize that we don't anticipate that programs will implement this new design by having trainees doing different amounts of time in each rotation. We anticipate that the usual block system that exists in most universities right now will continue. What will be different will be what will be taught and assessed while they're present on that service, ward, clinic, and so on. So where I said there is some flexibility, I want to emphasize it's not going to be the chaos of 20 different schedules, all of different lengths. Instead, it'll be flexibility around what will be taught and assessed on each rotation. So maybe I'll try and illustrate. I'm in emergency medicine. We have the 5-year emergency medicine trainee program. And we have blocks each year where a trainee is back in the home program doing core emergency medicine rotations. What they focus on in those rotations will be a bit more structured under the Competence by Design schema. My trainees also spend time off service, and while they're off service, they would have a number of milestones to achieve, meaning they demonstrate to a supervisor who signs off. If for whatever reason one of our trainees doesn't achieve all the milestones, there would be a dialogue with the program director about what other opportunities are there coming up in their scheduled rotations where they might be observed again trying to accomplish and achieve the level that's prescribed for them at that stage. I hope that helps with the scheduling issues. Next one, question about resources from the faculties of medicine and age of cutbacks. How will we get this done? So this is another recurring theme, and I think it's a legitimate series of questions that come around. Having enough resources to get this done. I want you to know that the college is trying to roll this out in a way that is resource neutral. The college is looking for aspects of training programs that we would say no longer need to be done. For example, fighters and many IDers will no longer be asked of majority of faculty that are supervising trainees. And that's because they have a relatively low yield in terms of the impact on trainee learning. Instead, we hope to substitute the less useful activities teachers are doing with really higher impact activities. Other things that require resources, such as aspects of the portfolio and faculty development, will be rolled out from the college. So the college is investing millions in this process, and that's to try and offset the impact on each program and on the faculties of medicine. Having said this, we're well aware that there are many changes that are already underway in faculties of medicine across the country and at various programs. So some of you are already ahead of us, and we're trying to catch up to the good ideas you're already implementing. So we know that there are resources in the system. Next one, following up on, quote, common competencies, how do we deal with differences or even conflicts of competencies between different specialties? I'm not sure what you mean by that question, so I'll ask that person to try and clarify if they could please type in again. I'm not sure what you mean by conflicts of competencies. I'm not sure what you mean. Next one, will this address the failure to fail for residents who cannot progress through? Yes. So the college will have policies that deal with individual trainees that cannot be remediated. And each university already has a series of policies and procedures that deal with trainees who are in difficulty. What this new system provides, though, is data. And when I talk to program directors from coast to coast and I talk to postgraduate deans, one of their biggest challenges is trying to help a trainee where there's a general sense that they're not quite where they should be, but there's not a lot of detail about what it is they need to address to get better. This new system will use all those milestone statements in order to help make a really clear diagnosis so we know how to intervene and help somebody. Just as there are today some people who are not well suited to a discipline, we think this data may help identify a small number of individuals who will not be able to progress. And they would enter into the existing policies and procedures that postgraduate deans already have in place. Is the manager role transitioning to leader? That is definitely being proposed. So I'll talk a little bit more about that. Early on, the Manager Expert Working Group, commissioned by the CanMed's 2015 project, co-chaired by Minka Chan from Manitoba and Deepak Dath from Hamilton, with input from a number of leading educators, proposed that the term manager needed to transition to the term leader. And what they meant by that was not that they saw physicians in the 21st century being the top of a pyramid again in hospitals, that sort of paradigm from our distant past. Instead, what they were trying to do was emphasize the idea of leadership competencies, that in the 21st century, every physician needs to know how to influence the healthcare system for the benefit of patients, to align practices with greater efficiency and effectiveness. So it's about leadership, but the way CanMeds lays out the CanMeds framework, we say physician as, so it'd be physician as leader. All right, next question. With the idea of specialty committees producing multifaceted assessment tools, should the tools we are using locally be updated and adapted to the available proposed Competence by Design Milestones release so far from the college? I'm not sure I totally understand that question, but I think the gist of it is, what should we do with our local tools? What I anticipate is that as each discipline goes through their cohort, their transition to the new system, they will be working with us using a number of standard Royal College templates. So for the first time, the college will actually provide assessment tools. And those are being developed by Farhan Banji, Yolanta Karpinski, myself, and a number of others. Those tools will have to be adapted and deployed across the country. For programs and sites that already have some tools that they really like, they can go ahead and use them, but the official ones to be uploaded into the portfolio will be the ones set by the specialty committee. For programs and sites that already have assessment tools they're using and their own discipline is not transitioning through a cohort immediately, yes, you can start adapting your language. However, the official change will not occur until your discipline deploys the national standards. There's still quite a number of questions on the docket, but I'm mindful of time. There's about 10 minutes left. So maybe I'll just give you a couple of other thoughts for today, and if I have any time left, I'll try and answer one or two more questions. If we don't get to your questions on the webinar, we'll try and email you afterwards, or we can always bring forward your question to a future webinar in the series. So all of this change, is it really worth it? Maybe I'll just give you a couple of slides to try and frame the conversation that's happening in medical education. Some of you may have seen this article in a series by this researcher named David Ash from the US. David Ash is a health services researcher, and he looks at outcomes from medical education programs, and he focuses on obstetrics in the US. There are a number of other authors in this kind of literature that's out there. Robin Tamblin's a prominent Canadian. John Norsini is another American that works in this area. And what I really like about David Ash's work is that he had access to a large database of American obstetricians as well as their practice outcomes. So he chose complications as a surrogate marker of competence, meaning that the more expertise you display, the assumption is that you'll have fewer obstetrical complications such as fetal or maternal mortality, infection rate, readmission, and so on. And what he produced is a very shocking, very reproducible series of results, and this slide is kind of a snapshot of that. And it shows that obstetricians in his database could be stratified into these quintiles and by their complication rate. So that in the fifth quintile, the complication rate was 13.6%, and the top quintile is about 10.3%. The complication rate being the composite of a number of outcomes. And this was very consistent over time, and it was predicted by primarily one thing, and that is where you trained. So basically our trainees appear to be acquiring the complication rate and by suggestion their competence based on where they train. That means our educational programs are so important. So all this work we're doing to try and improve our system, prepare it for the 21st century, is actually motivated by some of this work which says residency education, lifelong learning, critically important to patient-level outcomes. Okay, so ultimately for people like Andrea that I introduced to you early on in this webinar, this is about helping Andrea prepare for practice in a new way that takes advantage of the best of our system, but introduces some new educational technology to make her experience even more effective. We want Andrea to not only be excellent on her first day of independent practice, but also help all the Andreas of the world for their lifelong learning. Okay, so next steps. This fall you'll see the release of Series 3 of the CanMeds framework. We'll be working with that first cohort that I mentioned already to help them develop and implement their specific milestones. The Competence by Design e-portfolio is under development under the leadership of Craig Campbell, and we'll start to roll out the elements of that over the next few months. Accreditation, credentialing, and exam processes are all under reform as we speak. Okay, we welcome your questions. Even if you didn't get your question answered today on the webinar, you can type it in, you can email it to us, and we'd be pleased to try and answer them the best we can. Here's some sites you can reach us. So we have a Competence by Design mailbox that we monitor every day. There's a Facebook page and Twitter and LinkedIn for the Royal College. And we also have a number of Royal College Q&A and information pages on our Royal College website under the CBD moniker. We'd welcome your input. We really do want to serve you well and help you make this transition. We hope you're as excited as we are about these changes, and we hope to work with you on how to make the implementation as smooth as possible. Okay, time for one last question. How will self-assessments, self-reflections be assessed by evaluators? How will evaluators be trained to evaluate the e-portfolio? So the second question is a little bit easier than the first. There will be a faculty development program that will roll out for assessors and for the other roles within the Competence by Design project. Specialty committees will have a prominent role in that, and we'll be doing a lot of investment in program directors in Canada. Self-assessments and self-reflections, they'll be a part of the e-portfolio, will be dedicated to that. Whether or not they'll be assessed by evaluators will be up to each specialty committee, and so there'll be some assessment decisions to be made in terms of the strategy adopted discipline by discipline. That's all the time I have for today. I thank you so much for attending this webinar, for being interested in these changes that are coming down the pipe. Some of you on the webinar have even contributed, are co-authors of this work, and we're really pleased to have you with us. A quick reminder, a plug for the ICRE, the International Conference on Residency Education. That's in Toronto in October 23rd to the 25th. There will be more information. In fact, there's a whole symposium on CanMeds 2015 foreshadowing the changes that are underway, and another symposium on Competence by Design. If you are a resident or have trainees in your program, we would love to have them join us for the International Resident Leadership Summit. That's also in Toronto about the same time as ICRE. It's chaired and shepherded by Leslie Flynn from Queens. It's going to be an amazing program. Your trainees will come back changed and even more able to contribute to the life of your and culture of your group. We hope to see you there. Thanks for joining, everybody. See you on the next